Thank you for your patience. And maybe I will start. Okay. Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Student Scientific Society of Medical University of Silesia in Katowice, we would like to thank you for coming and taking part in the International Medical Congress of Silesia 2024. My name is Mikołaj Górka, and it's my pleasure to coordinate the session of clinical medicine with my dear friend Aleksandra Gładyś. I would like to cordially welcome the esteemed jury of our session, President of the jury, Professor Agata Stanek, and members of the jury, Dr. Mateusz Hermet. Dear participants, before we start the first presentation, let me explain you the principles and rules of the session. The order of the presentation will be the same as in the abstract book published before the conference. The maximum time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time of the prelection, he or she needs to move on to the conclusion and finish the presentation as soon as possible. Don't be afraid, we will let you know gently that the time just has passed. Please remember that all the presentation and the discussion must be run in the English.
Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work, and in that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. We kindly ask the jury to assess scientific value, way of presenting, discussion, and own contributions from 1 to 5 points. When the session ends, we kindly ask you to give the cards back to the coordinator.
So at the beginning, I would like to ask Kamil Mąksza to present the paper entitled Nutrition and Lifestyle of Oncological Patients, the Importance of Tertiary Prevention in Therapeutic Process. If you are ready, you can start your presentation.
Due to technical issues, every presentation will have the maximum time of 8 minutes and we'll change the slides manually, okay?
Dear jury, ladies and gentlemen, my name is Kamil Małkosza. I'm oncology dietitian and I have pleasure to present the thesis Nutrition and Lifestyle of Oncological Patients, Importance of Tertiary Prevention in Therapeutic Process. Tertiary prevention aims to prevent complications of chronic disease. These processes should be interdisciplinary and should include anti-cancer therapy with clinical medicine and also supportive treatment such as nutritional, psychological, and kinetic. These elements increase chance of therapeutic success, also thanks to biopositive strategies of patients. Nutrition and lifestyle are crucial elements in tertiary prevention because they significantly influence effects of treatment, clinical condition of patients, and quality of life. Role of dietary intervention is essential due to range of heterogeneous side effects resulting from disease and treatment. These include smell and taste disorders, xerostomia, dysphagia, constipation, diarrhea, nausea, vomiting, feeling of early satiety, also depressive symptoms and decreased appetite, which may be beginning of eating disorders and initiate malnutrition and also cachexia. In addition, anemia, metabolic, water and electrolyte disorders, and other disorders of systemic homeostasis. Therefore, nutritional status of cancer patients should be monitored at every stage of disease. Next slide, please. Main aim of study was assessment of nutritional behaviors of cancer patients. Specific aims included identify differences in patient strategies depending on age, gender, and type of therapy. Moreover, examine the range of dependencies between independent variables and behaviors of study group. Study group included 202 patients with colorectal cancer. The study was carried out in 2 Silesian hospitals and using snowball method. The research tool was original questionnaire. Inclusion criteria were diagnosed colorectal cancer, patient's voluntary consent, and traditional oral nutrition. Exclusion criteria were a failure to meet of any inclusion criteria, completion of tool inconsistently with instructions, and resignation during study. After study, each patient was offered individual nutritional education and dietary advices. Data were processed in Microsoft Excel and Statistica. Numbers and percentages were used in descriptive statistics. Chi-square test and Cramer's V coefficient were made to check statistical dependencies. P less than 500 was considered as statistically significant. Moving on to characteristics of group, more women than men participated in the study. Majority of patients were elderly with secondary education level, with excessive body mass, in 3rd stage of cancer, and treated radically. Moving on to results, half of patients did not use therapeutic diets, such as easily digestible diet. Almost 60% of respondents declared eating amount 3 meals a day, which may not be enough in this group. This fact may be related to frequent snacking between meals, but unfortunately, these were mostly products were source of simple carbohydrates. Many respondents declared consumption of fruit and vegetables in raw form, which in case of gastrointestinal cancer may worsen symptoms. Significant part of patients indicated many behavioral and nutritional problems, especially xerostomia, metallic taste, diarrhea, lack of appetite, and nausea. Patients admitted they could not cope with these problems. Many respondents noticed positive changes in nutrition during cancer disease compared to period before disease, such as eating highly protein meals more often, drinking more fluids, snacking less often, and paying more attention to food. Data related to hydration and frequency of consumption of sweetened drinks and ethanol are moderately satisfactory, as half of patients declared drinking 1.5 liters of fluids a day, and small percentage of respondents indicated frequent consumption of non-recommended drinks. Unfortunately, quarter of patients did not engage in physical activity at all. Positively, almost 75% of the study group noticed improvement in their current nutrition and lifestyle compared to period before disease. Moving on to comparative analysis, statistically significant differences were observed in meat preparation method and in type of preferred drink depending on gender. Women chose cooking and baking more often, while men chose frying more often. Women drank natural mineral waters and tea more often, while men chose juices and coffee more often. Further statistically significant differences were noted for frequency of fast food consumption and cigarette smoking, depending on age. Elderly people consumed highly processed products much less often. Middle-aged patients were more likely to smoke cigarettes during cancer. Moreover, statistically significant differences were noted in hydration level and in patients' opinion about role of nutrition and lifestyle in cancer, depending on type of current therapy. Patients treated radically were more likely to drink more fluids and were more likely to believe proper nutrition and lifestyle can improve course of disease. To conclude, analysis of behaviors of patients showed pro and anti-health activities in tertiary prevention due to importance of nutritional status, clinical parameters, and quality of life. It is essential and crucial to strengthen biopositive strategies among patients. Behaviors are unfavorable, require modification and nutritional education, which can be achieved by intervention of oncology dietitian. It was found that women, elderly, and radically treated patients presented more valuable biopositive strategies. It proves need to strengthen them, especially in patients with weaker health-promoting behaviors. Regardless of medium and weak dependencies between compared features, nutritional behaviors should be constantly monitored in all oncological patients because it is a really essential role of tertiary prevention in therapeutic process of cancer disease. I am really grateful. I encourage you to ask the questions.
Thank you so much for the presentation. Yes, applause. Now I would like to invite you all to ask the question and discuss the presenter paper. I'll remind you that the question can be asked both by scientific committee as well as by all participants, so feel free to take the floor.
Presentation, could you tell what was your contribution to this paper?
Thank you for this question. I conducted this study from start to finish. I thought an idea because oncological patients are really close to me in my location, in my environment. This group of diseases are really frequent. And this experience made that I thought this project, this study. I conducted this study from start. I made this idea, and I made this. Firstly, I prepared the main concept of the study. After I realized this study in two Silesian hospitals in Bytom and in Sosnowiec, and I worked with oncology patients. And besides using questionnaire, such a research tool, I prepared and I conducted nutritional educations with every patient who wanted. And after that, I prepared data. Data, and I prepared the results of my study under supervisor of my works tutor, and I would like to continue this study and I would like to connect this this research with my doctoral thesis.
Thank you.
Thank you.
Thank you for your presentation. And now I would like to invite Aleksandra Hejnosz from Medical University of Warsaw. Analysis of factor affecting the efficiency of syphilis therapy in people with HIV. Okay. Maybe online she will attempt.
Fortunately not, I think. So we can move this presentation to the end of the session.
Okay.
And I will proceed with the next one. We will kindly ask Maciej Szyduczyński to present the presentation entitled Risk Factors Analysis for Spinal Deformity Following Resection of Intradural Spinal Cord Tumors from the Post. If you are the second author, then feel free to get.
Dear committee, dear audience, my name is Natalia. I'm a third-year medical student and I'm representing Scientific Circle of Neurosurgery of the Medical University of Gdańsk. Today, I would like to present results of research risk factor analysis for spinal deformity following resection of intradural spinal cord tumors via posterior approach, systematic review and meta-analysis. Intradural tumors are rare neoplasm comprising about 30% of all primary spinal cord tumors. The majority of patients require tumor surgical resection, which is typically performed via posterior approach and includes techniques such as laminectomy, laminotomy, or laminoplasty. Spinal deformity is prevalent in populations undergoing posterior decompression and ranges between 10 to 30% in adults with an increased risk of up to 100% in children. These changes in spinal alignment may cause neurological deficits and interfere with the clinical improvement following tumor resection surgery. Therefore, the aim of our study was to identify predictive factors for the development of spinal deformity following resection of intradural spinal cord tumors via posterior approach. To achieve this, 3 databases were searched with the keywords presented above. Inclusion criteria for the studies were reporting resection of intradural tumor via posterior approach, reporting risk factors for postoperative spinal deformity, and articles written in English. Screening was performed independently by 2 authors to determine the adherence to the criteria, a minimum sample size of 10 patients, and sufficient amount of data to extract. Quality of publications was assessed using the Newcastle-Ottawa scale. Random effect models were utilized and patients were divided into fusion and non-fusion subgroup depending on whether the fusion surgery was required for the deformity diagnosis. Database search resulted in 11 publications included in the analysis as shown by the Prisma flowchart above. 11 articles reported 715 cases of patients with intradural spinal cord tumors. Among them, 25.59% developed postoperative spinal deformity. All of the studies were retrospective cohort studies. 5 of them were indicated as of moderate quality and 6 of them as of high quality. Mean age for all of the patients was 17.71 years old. Only 2 of the studies reported spinal deformity definition as a minimum of a 10-degree change in the Kopp's angle, while the rest of the studies failed to report an explicit definition of the deformity. Intramedullary group of patients was larger than the extramedullary group of patients. We extracted and tested 36 variables as potential risk factors, including demographic factors and perioperative data. Among demographic factors, age turned out to be statistically significant. Also, the presence of preoperative spinal deformity in patients was predictive for postoperative spinal deformity. Among intraoperative data, we identified thoracolumbar junction involvement as predictive for postoperative spinal deformity. Also, involving 3 or more levels during surgery had a p-value close to significant and showed significance in one of the subgroups. There were no differences between laminoplasty and laminectomy groups. Extent of surgical resection or histopathological diagnosis of a tumor weren't predictive for the postoperative spinal deformity. However, intramedullary location of a tumor showed significance in one of the subgroups. The age of patients of 13 years old or below was predictive for postoperative spinal deformity in both fusion and non-fusion subgroups, making it 3.72 times more likely to develop spinal deformity in this group. Also, the age of patients of 25 years old or below was predictive for postoperative spinal deformity, increasing the risk 4.03 times. Another risk factor with strong prediction for postoperative spinal deformity was the presence of preoperative spinal deformity in patients. As we can see, it was 12.19 times more likely to develop spinal deformity in this group. Analysis for the variable thoracolumbar junction involvement during surgery recognized it as a risk factor, increasing the risk of spinal deformity 3.11 times. In the fusion subgroup involving 3 or more levels during surgery was another risk factors for spinal deformity, increasing the risk 9.18 times. In the no-fusion subgroup, intramedullary location of a tumor also predicted postoperative spinal deformity, increasing the risk 3.67 times. The limitations of our study include the scarcity of reported definition of spinal deformity in studies, also lack of a standardized definition of thoracolumbar junction involvement during surgery, data coming predominantly from the US, which may limit the generalization of our study to diverse populations, and wide range of group sizes in articles, which may affect the statistical analysis and potentially overshadow some of the results. In conclusion, our study identifies significant demographic and perioperative data that predicts the development of postoperative spinal deformity in patients undergoing intradural spinal cord tumor resection via posterior approach. These results may help with more careful planning of surgical treatment of patients with intradural tumors and may contribute to the development of a scoring system used to assess the risk of spinal deformity following posterior decompression surgery. These are the references, and thank you for your attention.
Thank you for your presentation. We'll now move to the discussion part. We will now ask the jury to comment on.
Congratulations. It was a review paper and you used meta-analysis, but
Yes.
Did you publish this paper?
We are in the form of, we've submitted it recently, but we're waiting for the review.
But are you going to continue with the research at your center? Because I noticed that the authors are from the center from Medical University of Gdańsk and Apollo University.
Yes. We are supervised by one of the surgeons from Apollo University. That's why he helped us with this review. However, our research takes place at the Medical University of Gdańsk.
Yes, but it was only a meta-analysis, and you estimated the results of other authors. Yes.
Yes. Sorry, could you repeat the previous question, because I've been.
Are you going to continue the research in your centers on this topic?
Right now we're at the because we are We are working on few meta-analyses that are focused on spinal deformity following laminoplasty and laminectomy, like posterior decompression surgery. And we are right now in this part. However, we would like to move it to different kinds of, or to cohort studies. But right now we're like in a step of performing reviews and meta-analysis.
What's your contribution to this paper?
So I was, as a second author, I performed screening as well with quality evaluation of the studies and also prepared data for the regression in meta-analysis.
Thank you.
Thank you very much.
Thank you. Thank you once again for the discussion, and we will now proceed to the next presentation by Marcin Goławski, which is entitled Waist Circumference and Patient Survival, an analysis of primary care patients in lipidogram studies. The floor is yours.
Thank you very much. My name is Marcin Goławski. I represent the Department of Pharmacology of Faculty of Medical Sciences in Zabrze of Medical University of Silesia. Today, I would like to present the results of our research on the impact of waist circumference on the survival of primary care patients. Now, onto the introduction. It is, perhaps the most widely used obesity index is BMI, although some suggest that it doesn't fully reflect the metabolic health. Whereas waist circumference is another such index, which is often used in guidelines to determine abdominal obesity and metabolic health. In this research, we aimed to assess the relationship between it and patient survival. It is of particular note that we have previously analyzed BMI and survival in the same group, and I will also compare it to our previous results. It also must be stated that the current waist circumference cutoffs, which are presented in various guidelines, for example, 94 and 80 for males and females, or a different cutoff 108 and 88 for males and females respectively, are both arbitrary. So we decided to research if these cutoffs are indeed appropriate. So what were the lipidogram studies? There were a series of studies conducted in 2004, 2006, and 2015. They enrolled patients from primary care practices in the whole Poland. The exclusion and inclusion criteria did not concern specific clinical characteristics aside from only including adult patients. We also obtained survival mortality data from Central Statistics Office. As far as ethical approval is concerned, the respective studies did obtain it. And we used Cox regression to study the impact of waist circumference on patient survival. We used both the waist circumference, both as binary variable, where the elevated waist circumference was above 94 for males, 80 for females, and also as a continuous variable in a spline-based approach. And we also used both univariate and multivariate approach. which included age, smoking, hypertension, myocardial infarction in past, place of residence, education, and diabetes mellitus as the covariates. Now on to the results. As expected, patients with elevated waist circumference differed in almost all clinical aspects from patients with normal waist circumference. And as far as the relationship between waist circumference and survival is concerned, for male patients, for female patients, we observed that in the univariate analysis, the lowest mortality was found for waist circumference of 72%. In the multivariate it was 85%, centimeters. And is it changing, the slides? Could you move to the next slide? I think it doesn't work. Doesn't for me. I'm clicking and nothing's changing. Sorry. So the image is frozen on this.
Zrobiliśmy to, ale niestety nie jest tak, jak pan powiedział. Oczywiście czas jest zatrzymany.
Thank you. Is it working now? Yeah, it is. Thank you. So in males, the lowest mortality was found for 88 centimeters of waist circumference in the univariate analysis and 92 centimeters in the multivariate analysis. And in this analysis of a total of 44,620 patients, we have found that indeed waist circumference above the threshold of 194 for males and 80 centimeters for females is correlated with reduced survival. Importantly, it must be remembered that although in the multivariate analysis, the optimal waist circumference is higher, it must be known that this may actually represent the influence or the indirect influence of waist circumference on the myocardial infarction, hypertension, and also on diabetes mellitus, which may mediate some of the risk for death. And in the multivariate analysis, this is not this is not represented. And in fact, this increased waist circumference may not be actually fully beneficial. And the univariate analysis is more indicative of actual risk of a patient. In conclusion, we have determined that indeed waist circumference is an important predictive factor for patient death. It must be, however, noted that especially for females, the cutoffs are actually quite close. The cutoffs for obesity or abdominal overweight are actually quite close to the values we have obtained. And especially in patients who have comorbidities, it might be possible that the waist circumference is not the main factor which is reducing the survival. It also must be noted that because we have adjusted for age, it might be possible that in some older patients, in frail patients, the increased waist circumference may actually be protective in a way that it protects from malnutrition and wasting. So this indicates that further research is necessary to fully understand the appropriateness of measuring waist circumference, especially in contrast to BMI, in different patient groups. However, we have observed in this analysis that adjusting for additional variables does not influence the results as much, because in our former analysis, the multivariate analysis has shown that actually overweight and obesity are protective. This obviously is confounded by the factors we have adjusted for, but nevertheless, this shows that waist circumference is less susceptible to so-called obesity paradox, where increased waist circumference or BMI appear protective. It also must be noted that this, to our knowledge, is the first published study for Polish population, at least within the last 10 years. Thank you very much for your attention.
Thank you for your presentation, and now I would like to open the discussion.
Could you explain whether each subject with obese subject is sick?
It's obviously not the case that every obese subject is not sick. Sorry. It's the influence of obesity on different comorbidities is very complex, and it must be known that there are several factors. For example, the type of adipose tissue. It is obviously known that visceral adipose tissue is very much different from the peripheral adipose tissue in their hormonal activities. And it is actually the visceral, the abdominal obesity that is thought to be more harmful due to different adipokines secreted by this tissue. And in fact, waist circumference does measure the abdominal obesity much more than BMI does. There are obviously different genetic factors related to how the adipose tissue responds and secretes different adipokines that have different metabolic effects. So I guess these are, for example, two highly important factors that explain why the adipose tissue differently affects different people, and some people with excess do not experience as much comorbidities as others.
How your results are according to metabolic syndrome criteria?
Well, to be honest, I'm not sure what are you exactly asking. Do you want me to relate them to the most recent guidelines regarding metabolic syndrome? Yes. So I think the very important conclusion is that, okay, so we can go back right now to the presentation. But in any case, the cutoffs for abdominal obesity of the waist circumference don't clearly correspond. Oh, thank you very much. Oh, that is not skipping. In any case, oh, thank you very much. In any case, it doesn't seem like the very known cutoffs of, let's say, this is for females, so let's go for males. Okay, so 108. As we can see, the risk is pretty much constant in this region, and so is here. So we can see that these cutoffs may actually not be truly representative of any sort of points beyond which the risk rises exponentially. It might be possible or even beneficial to set the cutoffs somewhat differently to treat patients that are close to current cutoffs, but nevertheless do not meet them.
Thank you.
Thank you very much.
Thank you for your presentation. And now I would like to invite Barbara Nota from Medical University of Silesia with presentation titled Diet and Quality of Life of Women with Fatty Liver, Identification of intervention recurring behaviors.
Thank you. Should I share the screen? I will, or you can make it.
Yes, you can share your screen.
I should share, of course. I hope you can see my screen.
Yes, we can see you.
Great. Welcome, ladies and gentlemen. My name is Barbara Janota. I am a dietitian and a PhD candidate of the Department of Basic Medical Sciences in Bytom. I would like to thank you for the possibility of being with you online because of my health condition. Today it's really, really bad. I have fever. Today I would like to tell you something about diet and quality of life of women with fatty liver. Me and my department's colleague Anna Dolipska focus on the identification of intervention requiring behaviors. I'll change the slide. I hope you can see it. So a few sentences of introduction. What fatty liver is? It's a condition when the drops of fat accumulate in liver. It can be caused by metabolic disorders. It can be caused, of course, by bad diet habits. This fatty liver but dietary habits can impact body composition and quality of life, of course. So we decided to assess the dietary behaviors, body composition and quality of life among women with fatty liver. Here is the characteristic of our study group. We included 79 women with fatty liver. All of them were overweight or they had obesity. They were in age 20 to 84, and the average age was about 35. Most of them had the abdominal obesity. Here are the methods. We used two standardized questionnaires. First, to assess the dietary habits and nutrition beliefs. It's compound questionnaire, and the second one to assess the quality of life was created by World Human Organization. Then my supervisor assessed or diagnosed, is the better word, the fatty liver using the FibroScan, and then I assessed the body composition using InBody. Let's start with the results. Firstly, the general dietary behaviors. So here you can see that 34% of the study group declared that they don't consume meals regularly, and 35% of them add sugar to tea or coffee. I think it's a lot for that time, and when this woman knows that they have fatty liver, it's really bad behavior. Then we focused on vegetables, legumes, and fruits. Here you can see that the recommended frequency of consumption of vegetables is realized only by 22% of the study group of women with fatty liver. And what we observed, Anna Dolipska made the statistical analysis, we can see that as the frequency of vegetable consumption increased, the extracellular water index decreased. Then let's move to legume seeds. You can see that in line with recommendation, legume seeds were eaten by about 35% of the study group. It's recommended to eat legume seeds at least once a week. And we observed that when the frequency of legume seeds increased, the body fat percentage decreased, the visceral fat area decreased, and the waist circumference also decreased. And the last one, fruits. It's recommended to eat fruits once a day, and it's realized by about 50% of the study group, and we saw that when the fruit consumption increased, the body fat percentage decreased, and the visceral fat area also decreased. Then we decided to to check what is the healthy diet index. Below the slide, you can see which way we made it. And this healthy diet index includes those food products which you can see on the slide. And as you can see, this group of women gained only 24%, or 24 points of maximum 100 possible. It means that they have low intensity of pro-health behaviors, but unfortunately, about 65% of them thinks that their nutrition is at least good. Then we decided to check quality of life with self-assessment. Here you can see that this women with fatty liver assess their quality of life for 3.6 points out of 5 possible. And what's quite interesting, I think, the quality of life increased with increased frequency of vegetable consumption. It decreased with increased frequency of fast food consumption, and this joy level, also self-assessed, decreased with increased frequency of white bread consumption and with rice consumption. I think it can be caused by the disproportion of nutrients in meals of in this study group. That's my hypothesis. I'm sorry. And I think I could check it in my future studies, because I think they eat a lot of monocarbohydrates and not enough of proteins and good fats. And to conclude, the prevalence of improper dietary behaviors among women may negatively impact their quality of life. It will be, of course, beneficial to increase the consumption of vegetables, fruits, and legumes, and to avoid fast foods or low fiber products like white bread, like white rice, or products with a lot amount of simple sugars like sweets. These dietary behaviors can positively impact both metabolic health and the quality of life of patients. Here's the bibliography, and I'm sorry I feel too bad to answer your questions today. I think I can ask Dr. Ładyś for sharing my email address, so I can answer your questions online. Thank you, and I hope you will understand it.
Of course, I will pass the email if you feel the need of asking the questions directly to Barbara. And we'll now move to the next presentation, which is presented by Barbara Lewicka and entitled "Acceptance of Illness in Multiple Sclerosis Patients."
Good morning, everybody. My name is Barbara Lewicka, and I represent the Department of Rehabilitation in Katowice in the Faculty of Health Sciences. And my subject for today is acceptance of illness in multiple sclerosis patients. Oh. There is one slide that is not appearing, I guess. It's not working. Okay. So first of all, I will introduce you into this I guess, interesting subject. Then I will tell a bit about materials and methods, our findings, and the conclusion. So I think we can all agree that every health issue can cause some changes in our moods, inducing almost depression or in general some kind of worrying about our state. A progressive disease is a particular situation which is even harder because of its irreversibility. And so one of these progressive diseases is multiple sclerosis, which is a neurodegenerative disease, neurological, where people lose their abilities not only physically but also mentally. So in some individuals, the progressive disability can cause changes also in their own perception of their own bodies. According to the literature, the prevalence of depression is much higher than in general population, in the population of people with multiple sclerosis, and it can reach between 25 and 50% of people with this illness. Our study aimed to determine modifiable and non-modifiable correlates of acceptance of illness. Many studies show that psychological adaptation to the illness play important role in the general effectiveness of treatment. So it's very important for the patients to accept their illness and to just to have better results of the treatment of the disease. In our study, we included 96 multiple sclerosis patients from medical centers in Katowice. The study was conducted between January 2023 and January 2024. The mean age of participants of our study was about 42 years old, and the mean time since diagnosis was about 11 years. The distribution of sex was unequal, but it's normal in this kind of population because multiple sclerosis patients are mainly women. So it was almost 80% of women and 20% of male, and it's as I said, it's a normal distribution of sex in this disease. A part of these demographic questions, basic questions that we asked to the patients in the survey, we also used 3 professional questionnaires, which were acceptance of illness scale that we focused on the most. The second one was depression, anxiety, and stress scale. And the third one, body appreciation scale. So in the first one, the participants had to answer 8 statements and say if they agree or not. The statements were, for example, I have problems with adapting to the limitations imposed by the illness. And they had to say if it corresponds with them or not. And the depression, anxiety, and stress scale contains 21 questions. For example, it's difficult for me to relax. I don't feel any positive feelings. I think my life doesn't make sense. And the participants had to tell if it is their case or not. And the last one, the body appreciation scale, is a scale how the participants feel about their body. So they had to agree or not with the statements like, I feel good about my body, I respect my body, I pay attention to what my body needs. And there were 10 of questions like this. So as I said, we focused the most on acceptance of illness scale. And in our group, the lack of acceptance, which was the lowest possible score, range of scores, was for 20% of our group. The average level of acceptance was also almost 20%, and 60% presented good level of acceptance. We found positive association between acceptance of illness and the body appreciation scale score, and that was the strongest relation. Then we found negative association with all the three subscales of the second questionnaire that we used, the depression, anxiety, and stress scale. And additionally, we found a correlation between employment status of people with the disease and the acceptance of illness. Like people studying or working had a better score than people staying at home, which was also interesting. And of course, as we expected, we also found a correlation between the score of acceptance of illness and age, the neurological state, and time since diagnosis. To conclude, I would like to say that we found that the acceptance of disease is correlated with both modifiable and non-modifiable factors. So, of course, we can't affect, for example, the age or time since diagnosis of the patients, or even the neurological state can't be changed mostly. So what we can do is to provide these people more help, psychological help, to help them to work on their body image, to treat depression, and also to encourage them to go out from home, to study, to work, and in general to improve their state of mind, and by this to improve their level of disability. So the work on these factors should be taken into account in creating a complex program of rehabilitation treatment of this kind of patients. Thank you very much. These are the references. And thank you for your attention.
Thank you for your presentation, and I would like to open the discussion.
Congratulations. Could you explain us what are the modifiable factors of multiple sclerosis?
Okay, so the modifiable factors are the ones that we can change somehow. So we mean by this the mood of the patients and their state of mind and their attitude to the disease. So, for example, the body appreciation which can be changed by some psychological methods, or depression that can be changed by adequate treatment. And non-modifiable are, for example, age that we can't like stop or reverse. That is going. People are going older and older, so we can't affect this, but we can affect their mood, but by some psychological help, and that's what we meant by the modifiable factors.
Thank you. What was your contribution to this research?
So together with one of my colleagues, we chose these questionnaires to.
But your
mine
yes.
personally.
Not your colleague, but your.
Okay, mine. So I prepared all the questionnaire. I was introducing the questionnaires to the patients. I made the statistical analysis, and yeah, and I prepared the abstract and the presentation.
Are you going to continue with research?
Yes, we are continuing that. At this moment, the group is already bigger, but at the moment of sending the abstract, the group was lower than 100 patients. But for now, we have almost 150 patients, and our plan is to publish this work in a paper.
Thank you.
Thank you very much.
Thank you for your presentation. And now I would ask Marcin Goławski from Medical University of Silesia. with presentation titled Fasting Plasma Glucose and Mortality, a Survival Analysis of Primary Care Patients with and Without Diabetes.
So if you are ready, the floor is yours.
Thank you very much. Thank you. My name is once again Marcin Kołapski. Good afternoon. Today I would like to present the results of our more results of our research. That is the relationship between fasting plasma glucose and mortality in primary care patients with and without diabetes. What is the rationale behind this study? It must be said that the current guidelines, the current cutoffs for the diagnosis of elevated fasting glucose were set in 2003, and in fact had some arbitrary elements to them. In this work, we aimed to better assess the relationship between fasting glucose and mortality in a group of Polish patients from primary care practices. The patients included were those from Lipidogram 2015 study with mortality data available from Central Statistical Office from 2001. The inclusion and exclusion criteria did not relate to clinical characteristics of patients beyond attending to primary care facilities and the age above 18. In regards to statistical analysis, we utilized Cox regression to understand the relationship between fasting plasma glucose and mortality. We used both univariate and multivariate approach with such covariates as age, smoking, hypertension, myocardial infarction, place of residence, and education. And we used fasting plasma glucose both as continuous variable in spline-based approach and as a categorical variable. Now onto the results. In total, we have had data from 13,000 patients. Obviously, the characteristics of patient groups with different fasting plasma glucose levels different significantly. As far as the survival analysis is concerned, fasting plasma glucose obviously impacted patient survival. Statistical significance. Only the diabetes levels of fasting plasma glucose did, and there were too few patients with and the fasting hypoglycemia also did impair patient survival. Sorry, it doesn't change the slides again. I'm not sure why. Thank you very much. And in a spline analysis, we have determined that indeed in the univariate analysis, the lowest mortality was found for patients with fasting plasma glucose of 78 milligrams per deciliter. Although in the multivariable adjusted analysis, the lowest mortality was for almost pre-diabetic state. However, this must be understood in the light of the multivariable adjusted analysis, where some of the risk is actually mediated through age, hypertension, and myocardial infarction, and not the glucose levels directly. In patients without diabetes, at least without the diagnosis of diabetes mellitus, the glucose levels did not reach statistical significance in terms of mortality prediction. And nevertheless, similar results were obtained, and the lowest mortality was again almost pre-diabetic state in multivariate analysis, and univariate it was 84 milligrams per deciliter. Although again, this must be understood in terms of adjustment, where the glucose mediates its effects through hypertension, myocardial infarction, and other factors which occur with those diseases. Now on to patients with diabetes mellitus. Unfortunately, sorry, everything's okay. Yeah, we have found that fasting plasma glucose only reached statistical significance in terms of survival prediction in multivariable adjusted model. We have utilized the cutoffs of 90 and 130, with the reference being between those cutoffs. Those roughly correspond to well-controlled diabetes with glycated hemoglobin below 7%. Nevertheless, there were rather few patients with diabetes included, and this precluded reaching any sort of full conclusion in the univariate spline analysis. Although in the multivariable adjusted analysis, the lowest mortality was found in 190 milligrams per deciliter fasting plasma glucose. This overall indicates what is already well known, that the patients with diabetes should not be overtreated and reach glucose levels as in those without diabetes. Nevertheless, what is the most important result, I think, is the fact that in the whole population, the risk doesn't actually start increasing at 100 milligrams per deciliter, and even patients with glucose levels close to it who could still benefit from reduction, although it would be unlikely that it should be pharmacological. Lifestyle interventions would obviously benefit those patients that do not reach the cutoff of 100 milligrams per deciliter, although they may have some other comorbidities and may be close to reaching it. Overall, the glucose cutoffs are appropriate, although we must understand the limitations of using just the cutoffs. To my knowledge, this is the first such analysis in Polish population within the last 10 years of this analysis of this size. Thank you very much for your attention.
Thank you very much for your presentation. Now I'd like to open the discussion of your work.
Very interesting results. Did you publish these results because it's a part of the lipidogram study?
These particular results were not yet published, although I think it is highly likely that they eventually will.
Yes, I understand. Congratulations. I would like to notice that we can make diagnosis of diabetes when the patient level of glucose is 126. Yes, and you wrote that you qualified patient with fasting glucose above 125 also as patient without diabetes.
Yes, I understand. I understand your question very much, but
It's not true.
it's not exactly true because the measurement has to be repeated to actually make a definitive diagnosis. Nevertheless, the actual reason behind singling out the patients with diabetes is because patients with diabetes in general receive treatment, while the patients without it were first diagnosed.
Not diagnosed.
Yeah, they were not yet.
Which were not diagnosed.
Yes, those were patients not yet diagnosed with diabetes. I think this clarifies it because it's not, in the end, diabetes is also somewhat arbitrary, although there is more rationale behind this specific cutoff. Nevertheless, it's obvious patient with fasting plasma glucose consistently at 125 would also likely have some sort of complications later in life. Nevertheless, the main rationale behind singling out the patients with diabetes is because the treatment of diabetes may affect the outcomes because particular fasting plasma glucose reached with help of metformin or insulin would likely have different effects than natural levels of fasting plasma glucose. This is the main rationale behind this decision to actually include patients with fasting plasma glucose beyond 125, but untreated because not diagnosed.
Yes, but it should be mentioned about it.
Yes, I guess this is a very fair point.
Thank you.
Thank you.
Thank you for your presentation. And now I'd like to invite Karolina Sztuba from Medical University of Silesia with presentation titled Endoscopic Treatment of Craniosynostosis with Complementary Helmet Therapy, the Early Outcomes of Treatment.
Ladies and gentlemen, I would like to present the early outcomes of endoscopic treatment of craniosynostosis with complementary helmet therapy from the Department of Pediatric Neurosurgery. For starters, some crucial information on craniosynostosis itself. It is a result of premature fusion of one or more cranial sutures, which, if left untreated, can ultimately lead to brain tissue damage. It occurs in about 1 in 2,500 live births and can be divided into various subtypes based on which suture is affected. Most commonly, the affected suture is the sagittal one, and it's responsible for more than half cases of craniosynostosis, and it presents as scaphocephaly. Other types are coronal, lambdoid, and metopic craniosynostosis. The treatment option for such defect is surgery, which can be performed in various ways. For many years, the primary line of treatment was open cranial vault remodeling, which had good results, but it's a major surgery, it is a complex surgery. So in the 90s, some minimally invasive correction possibilities emerged, and they include spring-assisted distraction and endoscopic suture removal with complementary helmet therapy, which is the subject of this study. To shed some lights on the methods I mentioned, I will say a few words about them. Open cranial vault remodeling requires complete removal of skull bones, which are then manually reshaped and remodeled and inserted back. It is, like I said, it's a major and complex surgery, as you will see on the next slide. But once it's done, it requires no further intervention. If everything goes well, there's no need for any other intervention. These are the highlights from this surgery performed by our neurosurgery team. And the remaining options are way less graphic. Spring-assisted distraction relies on a spring that's inserted between the skull bones, and the spring is supposed to widen the gap between the skull bones, but second intervention is needed to remove the spring once it has done its job. Endoscopic suture removal starts with small cuts on the head. The endoscopic instruments are then inserted. The affected suture are removed with a small margin, and afterwards, long-term helmet therapy is required to complete the treatment. On this slide, we can see one of the patients from our study group operated endoscopically for scaphocephaly. Over here, he is prepared and positioned for the surgery. And here we can see the course of said surgery with pieces of bone removed endoscopically. The aim of this study was to analyze the early outcomes of endoscopic treatment of craniosynostosis with complementary helmet therapy. And for this purpose, a retrospective study of children treated for craniosynostosis using endoscopic surgery with complementary helmet therapy in the Department of Pediatric Neurosurgery in Katowice between 2021 and 2023 was performed. Their radiological findings, clinical picture, and postoperative outcomes were analyzed, and their follow-up data was collected during their control and orthotics workshop visits. The results were as follows. The population consisted of 11 patients. Most of them were male. Median age in time of operation was 4 months. The youngest child that was operated on was 2 months. The oldest one was 5 months old. In this group, scaphocephaly cases dominated with 5 cases. Other than that, we had trigonocephaly, plagiocephaly, and 1 case of brachycephaly. 5 patients underwent sutures ultrasound, which gave a clear diagnosis of craniosynostosis in 4 cases. 1 case required additional exams. All patients had CT scans performed in order to confirm the diagnosis and to plan the surgery. Their skull parameters and brain morphology information was also gathered. All scans confirmed the diagnosis of craniosynostosis. 1 turned out to be a bilateral coronal craniosynostosis, and 1 case had the suture closed only partially. Other than that, cranial index, which is a, I don't know how to point it, which is a skull width to skull length ratio, was decreased in scaphocephalic cases and was increased in the brachycephalic case. Frontal angle in trigonocephaly was decreased. Perivascular spaces turned out to be dilated in 4 patients. Scaphocephalic cases underwent endoscopic cranial vault and base remodeling, and the others underwent suturectomy of 5 to 10 millimeter width. Red blood cells transfusions were required by more than half of the group. They were required by 6 patients. The side effects, the most frequent side effect was eyelid edema, and 5 children suffered from it. 3 children suffered from mild infections. However, no neurological disturbances were observed. The children left the hospital usually after 6 days. The median time of onset of helmet therapy was 26 days after the operation, and it lasted about 6 months. The longest treatment lasted 9 months, and the shortest one never really started because the family dropped out of treatment, resigned from treatment right after the operation. The helmets are designed for each patient individually based on their head CT scans, and they are 3D printed, and they are not funded, unfortunately. And such helmet costs around 9,000 zlotys. Most patients needed 2 helmets in course of treatment. So as we can see, this is a good kind of therapy, but it's not flawless because it is a single procedure. It's less invasive than open cranial vault remodeling, but it can generate great costs for the family. And it's not very comfortable since it requires wearing a helmet 23 hours a day for at least 6 months. So the family's compliance is crucial to achieve the desired effect. And such compliance was an issue in 3 cases. 1 child also developed a pressure sore from an incorrectly worn helmet. But even despite that, 9 out of 11 cases achieved satisfactory outcome, and median cephalic index increased into the range of norm. Visible outcomes of the treatment can be seen on this slide, as well as on this slide. What we can deduce from this study is that endoscopic craniosynostosis surgery with helmet therapy is both safe and effective, but it's not for everybody. The decision on treatment should be made individually for each patient, taking into consideration the family's compliance and their material capability to provide multiple helmets during the course of treatment. Early outcomes are promising, but of course, further exams are necessary and they will be done in our clinic. Thank you.
Thank you very much for your presentation, and we'll now move to the discussion part.
Thank you for your presentation. What's your contribution? It's the first question. And what are the limitations of your study?
The contribution was, of course, data gathering and analysis. I also prepared the abstract, the presentation. And the limitations are, well, it is a small group because it's quite a rare defect. Basically, most of children's neurosurgical problems are quite rare, so the groups are smaller. So it's not very representative. And of course, this study should last for many, many years before we can conclude anything for sure. Another obstacle, I think, is that this therapy is not funded. So many people maybe would like to undergo this kind of therapy and would qualify for this kind of therapy, but simply cannot afford it. And another obstacle, I think, is just working with another humans.
What are the results of other centers? Could you compare your results with other centers which perform such procedures?
Could you please repeat?
Did you know other centers which perform such procedure, and your results are similar to the other centers?
Well, there is no proof of superiority of one single method. And this subject has been brought up this year at the Pediatric Neurosurgical Conference. And it turns out that every center has their own opinion, and they prefer the kind of surgery that they perform mostly. So it's hard to tell which is best. This minimally invasive surgery is only reserved for younger children. The open vault surgery is for older children, and this can be only performed up to 5 or 6 months maximum. And there's literature that says that the sooner the better outcomes are for the children. So I think this could be potentially the future, because we want to get done with it as soon as we can to achieve best neurological outcome. However, thousands of children operated worldwide with the open method also are doing quite well. So it's not like one is definitely better than the other, and every center will be doing only one. It's still a subject of very heated discussion among neurosurgeons.
Thank you.
Thank you.
Thank you very much. That was the last presentation which was scheduled for today, but before we finish, I would like to ask if Alexandra Hejnosz has joined us online, or is she absent today? Alexandra, are you with us?
All the submitted papers has been presented. We congratulate all the authors and participants of our session. We hope that you enjoyed this time, and the time exchange of views and observation will contribute to increase our medical knowledge. At this point, I would like to ask the president of the jury, Professor Agata Stanek, for a few words to sum up the session.
Dear participants, I would like to thank you for invitation, and I would like to congratulate you the interesting speech, topics, and for great discussion, because it was very great. And I wish you to publish your results in good journals. Fingers crossed we keep. And we invited you because it's a student conference for future, for next year. And I would like to invite you to the doctoral days, which will be organized in June 24. Thank you.
Thank you for these words. Yes, applause, of course. At this point, we would like to express the words of thanks to the members of esteemed jury. We truly appreciate your valuable comments, accurate observation, and work on the presentation assessment. Dear participants, we would like to cordially invite you for the decorating and closing ceremony of the SIMC 2024 conference, which will be held in Radio Theatre on the 17th of May at 6:00 p.m. Ladies and gentlemen, the clinical medicine session comes to the end. On the behalf of Student Scientific Society, I would like to thank you all for participation in this session and wish you a very nice day. Thank you.